So, what the procedure, the newer procedure that I want to tell you about that we've been doing for a few years and is being studied now is called the convergent or hybrid ablation. And the thing about this procedure, it combines both a catheter ablation and a surgical ablation, both on the inside and the outside of the heart. So, once we do both surfaces, our impression is, but that's why the study is that this is a more comprehensive procedure and it involves both the electrophysiologist. So I'm a cardiologist, subspecialized and trained in cardiac electrophysiology and the catheter procedures. And to do this procedure, I work with a surgeon who trained as a surgeon, subspecialized in cardiac surgery and then in the arrhythmia surgery. So let's see if this is a video, a cartoon video of how this procedure works. So the surgeon starts, and this is he passes a scope up under the xiphoid process-sternum to the heart. And this is the view he gets of the back of the left atrium, and that's what the 4 pulmonary veins look like coming in. And this is his catheter. He's delivering ablation lesions by heating the tissue on the back of the heart. So this is the left atrium, and these are the 4 pulmonary veins. And this is a better graph because these are a better picture because these are big structures like this. And it turns out that they harbor most of the abnormal electrical activity that causes atrial fibrillation. And to electrically isolate them, we need to put scars around where they join the atrium. Now, this does not impede their function as blood flow tubes, but it will impede electrical activity. Electrical activity cannot pass through a scar. So once we produce these scars on the surgical approach, and again, our surgeon, currently Dr. Bundy, is working through a scope to create these series of ablation lines. And now Dr. Bundy finishes his procedure, and I or one of my colleagues pass a catheter through the veins up inside the heart, inside the left atrium, and this is the inside view. And you can see that there are areas that he cannot get to with that approach and that we can complete. So that at the end, we've encircled where the 4 veins come into the left atrium and the posterior left atrial wall of the heart. And that has been found to be needed to stop persistent atrial fibrillation. And in our hands, the results of this procedure have been good and very encouraging, enough to encourage a major national trial of the procedure. So that procedure is carried out with somebody under general anesthetic. It's a 2-team approach. The surgeon do their part on the outside, we do our part on the inside. Then there's a recovery period, obviously, from this procedure, and that is called the convergent or hybrid ablation procedure.
We appreciate your interest in considering the Watchman device for the treatment of atrial fibrillation in patients that aren't able to take anticoagulants. If you qualify for this procedure, this is a procedure that is done within the hospital. You will undergo general anesthetic. We will then seek to get access in the right femoral vein, take a catheter up into the venous system, and go up just past the heart, at which point we will get our equipment ready in our attempt to get into the left side of the heart. The appendage, which is the area of our concern and the area we want to obliterate, is on the left side of the heart, and so we'll need to cross over into the left side of the heart. We do this with what's called a transeptal catheter. The catheter will help us locate a spot where the tissue is relatively thin between the right and left part of the heart. We'll then cross the septum with a needle and then pass our catheter into the left side of the heart. At this point, we push the catheter and our wire into what's called the pulmonary vein, which is a good landing zone for this relatively large catheter. As you can see, the appendage lies below the pulmonary vein. There are different types of appendages, which is apparent and is very important to us as we attempt to determine which size device to use. At this point, we replace the catheter with what's called a pigtail catheter, and we navigate ourselves into the appendage, at which time we make appropriate pictures to determine the size of the appendage as well as the shape. At the same time, our colleagues who do the imaging with the transesophageal echo are confirming the same things in regards to size and shape. As you can see, the catheter is marked and helps us determine the size of the device we need. At this point, we take a confirmatory picture of the appendage with contrast dye, and then pick out the right size device to use. The device is then loaded through the leg, through the catheter, up into the appendage. At all times, the device is tethered so that if we have any difficulty with the location, we can pull the device out. The device is then placed deep into the appendage, and as it's slowly removed, it opens up. The device is made of nitinol and has a PTFE covering that initially is permeable and allows blood to flow back and forth. Over a period of about 30 days, the device gets tissue over it and now no longer will allow blood flow from the appendage back into the left atrium and hopefully therefore prevents clots from going back into the central system. As mentioned, the device is tethered the entire time. If we feel comfortable with the position, there's no leaks, and it's well positioned, we release it. At this point, the patient's able to go home the following day. They are on Coumadin for approximately 30 to 45 days. At this point, we get an echo, and if the device looks good, they just go down to a baby aspirin and Plavix per day for a total of 6 months, and then just down to a baby aspirin.
My name is Jet Kraus. I'm in the cardiac cath lab in Carbondale, Illinois, and now in the new electrophysiology lab. We do cardiac ablation here in the electrophysiology lab, and we take people who have had atrial fib and send them away without atrial fib. It's a flip side of the cardiac cath lab, and I'm grateful to be here. It's very different.
I'm Daniel Correia. I'm an electrophysiologist or electrician of the heart with Prairie Cardiovascular in Carbondale. We started doing ablation procedures at Memorial Hospital about a year ago, and we've performed over 100 of those procedures this far. We work concentrating primarily into the electrical issues that can give rise to abnormal heart rhythms, fast or slow heart rhythms.
Care begins before we roll in the door. When we greet the patient, we want to automatically start giving them the assurance that they're in the right place and in the right hands. And we get them on a table in an unfamiliar place and get them hooked up to 20, 30, 40 wires, depending on the case that we're at. It's very discomforting for the patient, and so we want to give them assurance around every corner. The patients in the EP lab are sometimes sedated, and sometimes they simply receive conscious sedation. Much like drawing pictures on an iPad, which everyone today is familiar with our 3D mapping process, we have the ability to actually take a catheter inside the atrium of the heart and draw a three-dimensional picture of the left atrium of the heart. Just like a photographer having two cameras, it enables us to have the two best views of the heart at the same time simultaneously. One camera will separate the top of the heart from the bottom of the heart, or the atrium from the ventricle, while the other camera will separate the right side of the heart from the left side of the heart, the left atrium from the right atrium.
Well, it means that we have the capability of performing the electrophysiology procedures that any tertiary or quaternary hospital has. We have the same or better equipment than most university programs in the US. And we have a fully developed team dedicated for electrophysiology to take care of them during this process.
The doctor has 4 additional sets of eyes on the cameras besides his own. He has the monitor tech observing the electrograms continuously. He's got a scrub tech helping him with all his equipment. He's got an x-ray tech that is helping with the imaging and the images. And he's got a nurse at the head of the patient, giving the patient assurance, delivering medications as they're needed. An electrophysiology exam involves multiple catheters, each catheter attached individually, separate cables to the computer system, so that we have internal electrograms of each individual spot along the electrical pathway within the heart. When we find a pathway that's not normal, that's when we'll do an ablation. An ablation is a creating of scar tissue across the pathway that's not supposed to be there, so that the electrical will be diverted back to the pathway that is supposed to be there. With the addition of electrophysiology to Prairie Heart Institute's cardiovascular program, we have almost completed the circle of what we can do for patients in Southern Illinois.
I feel good, and I feel that I could help somebody, that a person might be feeling better because of something that we accomplished. I feel good when I feel that we have done our very best to try to help that person.
So I know I have been talking about cardioversions for the treatment of or management of AFib, AFLOD, and SVT, correct? So let's get more in depth about learning about cardioversion. So per your book, page 737, electrical cardioversion involves the delivery of a timed electrical current to terminate a tachydysrhythmia. So when I say time, it means that the defibrillator is set to synchronize with the ECG on a cardiac monitor so that the electrical impulse discharges during the ventricular depolarization. So, what complex or what ECG, what part of the ECG is that? Ventricular depolarization or your QRS. Okay, so the reason for doing that is the synchronization prevents the discharge from occurring during the vulnerable period of repolarization, meaning your ventricular repolarization, which is your T wave, because if the shock goes or if the shock happens to be on a T wave, it could result in a VT or ventricular tachycardia or ventricular fibrillation. So that's the purpose of making sure it's on a sync mode. Um, it's important to ensure also that the patient is connected to the monitor and not and to select a lead, not paddles, because it has the most appropriate sensing of the QRS, right? So now, if the cardioversion is elective and then the dysrhythmia has lasted longer 48 hours, remember anticoagulant or anticoagulation for a few weeks before cardioversion may be indicated. Okay. Digoxin is also withheld for 48 hours before cardioversion to ensure that resumption of sinus rhythm with normal conduction. Is the patient NPO? Yes, patient is instructed or instructed not to eat or drink for at least 4 hours prior to the procedure. um, Obviously, the patient will receive moderate sedation as well as analgesic medications because you can see these patients once they get shocked. You can feel the pain, and you would see some facial grimacing and muscle guarding, stuff like that. I've seen firsthand that a lot of them shout as well once they get the shock. They are a little bit awake. They're conscious, called conscious sedation. Um, or moderate sedation. They're not supposed to be awake, but we give them something to help them fall asleep a little bit. The amount of voltage for these patients varies from 50 to 360 joules, depending on the defibrillators technology, the type, and the duration of dysrhythmia, and the size and hemodynamic status of the patient. So you would know that cardioversion is successful if there's a conversion of your atrial arrhythmia or your tachydysrhythmia to sinus rhythm. You would know it also when there's adequate peripheral pulses and there's great or good blood pressure. Okay. Remember, because of the sedation, the airway patency must be maintained, and the patient's state of consciousness should be assessed all the time. Vital signs and O2 sets are monitored and recorded until the patient is stable and recovered from sedation and analgesic medications or anesthesia. It is important that the patient is on ECG monitoring during and after cardioversion and on continuous cardiac monitoring. So obviously, these patients are not, or this procedure is not done outpatient, as an outpatient area or department.
How are you doing, man? Are you with us? Okay. We're gonna keep talking to you until you're not with us.
I'm gonna get ready to.
If we have to give you more, we'll give you more.
Here, I'll get another.
How are you doing? Still with us a little?
I'm next. Dick's next.
Can I get some of this tonight? Just
How are you doing, man? Johnny.
All right, charge it up. All right, clear.
yeah.
Sorry, man. You're done. You're done. All done.
Johnny?
Relax.
Johnny, how you feel?
Relax. See if he's not fully sedated. That was pretty sedated.
How many joules was that?
200.
That was
Johnny? Hi,
How you
Johnny.
doing, man?
How are you?
What's the half-life on that?
Oh,
Short.
Did
He'll
you
be in 2 minutes. He'll be done.
Did we convert?
In the fucking... Wow.
He won't remember that.
What's his rate though?
Like 130. But if I shocked you right now, you'd be at 130.
Holy
What do you remember? What do you remember?
Well, just wait 5 minutes. He won't remember.
He won't. Why is he remembering now?
he just thinks he's remembering right now.
He's dreaming.
kick my fucking ass.
I don't think he was out.
He was.
Was he?
He wasn't dying. He wasn't responding.
Yeah, we woke him up good.
You take that?
Oh yeah.
his hand.
Oh yeah. That's totally good. I know. That's fine. Right?
It was his idea.
Yeah, it's
He's
his
the one
phone.
officer. Did it work?
Oh, it's his
Yeah.
phone?
Yeah.
Wow. That was a friggin'. Ooh.
How are you feeling?
Okay, so much for atrial rhythms. Now we're going to talk about ventricular rhythms. Ventricular dysrhythmias originate from foci within the ventricles. So this includes your PVCs, the VFib, and the VTAC, and your EDO. So basically, again, we're by using the objective, we're not going to be talking about the rest of the other rhythms in here. So what I want you to know by now, we just want to learn the basics. I want to show you what a VTAC looks like, what a VFib looks like, and how we're going to manage this life-threatening dysrhythmias.